we're going to get started. We welcome you to AO Link Session 10 on acetabular fractures. AO Link is a medical student webinar series designed specifically for students. And this is AO Link 2.0, our second year educating and interacting. And we're going to get going on our 10th session. We appreciate the support from Dr. Lee and Dr. Kapatkin on AO leadership. And as always, our leader, Dr. Akers, with us tonight. Any words, Dr. Akers? We head into session 10.
No, I'm just so appreciative that folks continue to 2.0 is coming to a close, but I would remind all the students to keep a watchful eye out for Link 3.0 coming in the next month or two to a computer screen near you.
Sounds great. I'm Phil Mitchell out of Nashville, Tennessee, and Taylor is with us tonight as well, who's going to be handling the clickety-clacks, the ones and the twos. Any questions he'll be helping to answer. And so we have great guest faculty tonight. I'm going to have them both introduce themselves, and then additionally, Andrew and Patrick, comment maybe on your best AO memory. I just saw Taylor in Henderson, beautiful Henderson, Nevada, and that for me is now a top 5 AO memory. What's your best AO memory? Andrew, let's start with you.
Yeah, so I'm Andrew Tyler. I'm coming from Texas Tech El Paso. I'm actually Taylor's partner. Honestly, my favorite AO memory is Henderson, Nevada. That was my first AO basic course that I was teaching, and I had a blast, and I would love to do it again sometime.
That's awesome. All right, Patrick, what do you got? Best AO memory, and then where you're coming from.
Yeah, so I'm Patrick Kellum. I'm at the University of Texas at Houston with Dr. Aker. And my favorite AO memory is probably being able to go to Davos, to the center of AO where it was all founded in Christmas time, and being able to do a course there and see the headquarters and be able to experience what AO Davos really is. That was an incredible experience that I'll never forget, and definitely a top 1 experience for me.
For sure. The history is so rich of this organization and continues to just drive more and more folks to be involved, to volunteer, and to give their time. And for those that don't know, AO Basic is a entry-level fracture course that most interns and residents teach. And for many of us, our introduction into the organization, such an impactful moment. So to Andrew's point, to be able to spend time doing that, hopefully passing more enthusiasm and passion on is really amazing. So this is session 10, acetabular fractures. You see where we've been. A plug for AO milestones again, a pathway, a portal for you all as you go into your surgical training that's really going to be a very helpful resource. So we encourage you to check this out and take a look at this QR code as well. And then finally, use the Q&A box for any questions that come up. We'll be monitoring that really closely. We love the questions. They're always so excellent. So if you've been here for all 10, claim that Credley badge, get your final merit badge, put it on your applications for next year. We believe you should be rewarded for sticking with us and learning so much about ortho trauma. We're so happy for you guys. Just to recap briefly, we've reviewed knee in the past 2 sessions. First, about infection, about how to aspirate knees, how to diagnose a knee infection. So if you want to know more about that, if you haven't seen those, session 8 would recommend looking at that. And then last month, Taylor and the crew reviewed some knee injuries, some specific to the extensor mechanism here, quadricep rupture on the far left, a non-displaced patella, a terrible stellate patella on the right, so kind of escalating levels of extensor injury, but also ligament injuries, looking at ACLs and how they're repaired, posterolateral corner injuries and how those are managed, and then finally the end of the line, the knee dislocation, and then demonstrating some really excellent images as well, some cross-sectional imaging with vascular injury and how your antennae really need to be up for those types of associated soft tissue injuries when you encounter a knee dislocation. So we're going to go quickly to acetabular fractures. I think it is a big topic. We've got goals tonight to cover, and they include first to just cover the acetabular fracture patterns and the classification. We want you to leave and have a knowledge that there is a classification scheme and how you may, just based on a plain film, place some of these injuries into a classification and really impress your faculty when you're sitting in clinic or getting ready for a case. Secondly, how to perform a hip reduction and then placing traction and what the indications of that may be. And then what are some of the pearls about when to do it and when not to do it. And then thirdly, looking at acetabular imaging, understanding what you're seeing and applying it to cases. Lastly, some introduction to surgical approaches and when you want to do surgery and maybe when you don't want to do surgery. So a lot to cover. We've got 7 excellent cases that'll get us there. Here we go. So this is a picture that you'll see commonly as we kind of discuss acetabular fractures and their anatomy. Andrew, what should a student know about this picture? What is the takeaway from this pictogram?
Yeah, so I think a lot of medical students get caught up on a lot of these anatomic terms, AIS, cotyloid fossa, what's this, what's that? And really, I think if you take one thing away from tonight, it's this column theory of the acetabulum. And what we mean by that is looking at this central image, you basically have 2 columns that form kind of a lambda, or if you really can think about it as an arch, with the acetabular cup kind of as the keystone of the arch. And that creates an architecturally kind of strong weight-bearing surface that transfers the weight into the sacroiliac joint through that sciatic buttress. And so on the left, that's kind of how we think about at the acetabulum, with the red being that posterior column and the blue being that anterior column.
That's a great introduction. You're going to hear column probably 100 times over the course of the next hour. And so this is a really fundamental part of acetabular fracture management, is an understanding of how the columns are related to the hip socket. So the other takeaway that we want you to have is about the classification scheme. So Patrick put this slide together. I think it's so helpful as you are in clinic and you're asked to describe what an acetabular fracture is, and you're asked to use this classification scheme. So Patrick, explain this SABRE concept to us.
Yeah. So it was described to me that Letronel, who is the godfather of acetabular surgery, explained this to people as the 10 different types of acetabular fractures, or general types, that he found. And there are 5 elementary fractures, or kind of simpler fractures. And then there's 5 associated fractures that are more involved. They're more complex. They have more than one part to them. But the elementary fractures were described as one swipe of a saber. It's a fracture that could be made with one swipe of a sword across the acetabulum. And so the posterior wall, the posterior column, the transverse, the anterior column, or the anterior wall can all be made with just one line across the acetabulum. Whereas the associated fractures, you have to take 2 lines, or if you were to draw with a pencil, you have to pick your pencil up, or the swipe of a saber, you have to swing twice or 3 times for these fractures. So what we would like you to know in clinic is that there is a classification scheme. They're set up between simpler patterns and more complicated patterns, and they're all based on the theory of walls and columns, and what's injured and what's not, and that there are 10 of them. And as you get a little bit more in your training, you can start to learn about them. But this is the general classification scheme that we tend to use to drive the way that we fix these fractures.
Awesome. Yeah, I think it's really helpful to see this shown in a pictogram. We're going to show some cases that represent some of the most common types. So if this is new to you, it's a lot to take in. Just write Letronel down and Google later to refresh. And again, this is low-hanging fruit, questions in clinic that you may be able to knock out of the park. So let's start with this first case, Patrick, a case of yours. Tell us what you see on this film.
Yeah.
Here.
So this is a 16-year-old gentleman that was playing football here in Texas, which is a big deal. And he was tackled and had immediate left hip pain. He came to the emergency department and had this hip film. So I think what I'd want you to take away as a medical student is that the hip is dislocated. I mean, that's what everyone's eye is drawn to, but it's very important to see that on the left side, the femoral head is not underneath the dome of the acetabulum or within the hip socket. It is dislocated in its cranial or proximal. I'd like you to see that the hip itself, or the femur itself, is internally rotated. You can see less of the lesser trochanter, the little bump that's on the medial side of the proximal femur, more so than you can on the other side. I know it's a little bit of a clouded view because of some opacities over there, but you can see less than the other side. You can see a little cranial piece of bone. There's a little wafer of bone here behind the femoral head that will turn out to be what we call the posterior wall, but that is another piece of bone that you can see, and that's likely associated with your fracture dislocation. And that I want you to see that if you follow these lines that we'll go over in a little bit, that there seems to be a bite out of one of they should be nice curves. One seems like a mouse took a bite out of, and that's maybe where that bone fragment goes. But those are some things that I want you to see in this film. Otherwise, we can go over some lines later, but the rest of the pelvis of this patient is fairly normal.
Nice. So, Andrew, walk us through residents going down to the emergency department. They're seeing the hip dislocation. Obviously, that's something is wrong, and my first maneuver, my first instinct will be to just pull on the leg. But what needs to be done before we get to that point where we're getting the sedation and we're getting up on the bed and hogging on things? What's part of the physical exam for these patients? What should be routine?
Yeah, exactly. So, I mean, everybody wants to kind of jump and pull on the leg, but there's a lot of other things going on that we want to make sure we account for before we just go start yanking. And so, first and foremost, we want to know if this is an open versus a closed fracture, if the bone is exposed versus if it's still contained within the skin. And particularly for pelvis and acetabular fractures, you really got to go searching for them. They can pop out in surprising places. So the perineum, kind of in the genitals, in a lot of areas that they might be pretty well hidden. So you have to do a really good physical examination in possibly some uncomfortable areas to make sure that you appropriately document everything. Next, you obviously want to look at deformity. That's what everybody's in the trauma bay is going to be pointing at. For a posterior dislocation, it's probably going to be short. You're probably going to be internally rotated. For an anterior dislocation, you'll probably be externally rotated. But these are just important things to note, which gives us clues as to what kind of injury is going on. Finally, you want to pay very close attention to the skin. And so this is a very particular finding for acetabular fractures. We talk about bruising over the pelvis and hip. It's known as a Morel Lavallee. And it's basically where you have an internal degloving of the skin and soft tissue from the fascia. So effectively, you can get a big hematoma in between those layers, which definitely affects your surgical plans. You don't necessarily want to make a big cut in that area if you don't have to, but can definitely dictate how you're going to treat these fractures. And then finally, you want to make sure you ask and look about previous surgeries around the acetabulum and around the pelvis. For example, here we've got a great image of a hernia within the scrotum, but you want to ask about C-sections, about if they've had hernia repair. Is there mesh that we're going to encounter if we do any of these operations? All this really helps us plan for further care.
Nice. Yes. So this is a picture on the top, just to clarify, the skin on top of this looked normal, but underneath there was incredible undermining in this Morel Lavallee lesion. So such important key points. Patrick, give us a takeaway from a neurovascular exam. Do you need to study on a hip dislocation every single dermatomal distribution shown on this diagram here?
Yeah, no, the large portion of physical exam involves the musculature and sensation distal to the hip. It's always important to do a complete physical exam, but this is mostly a spine exam. What we really care about with acetabular fractures and acetabular fracture dislocations is the status of the neurovascular exam distal to the hip. So do they have a sciatic nerve palsy? Can they move their foot up and down? Is it isolated to a certain branch of that nerve? Can they push their foot down, but they can't pull their foot up? Can they feel the top of their foot, but not the bottom? Can they feel the bottom, but not the top? And then can they feel in the inner parts of their thighs where an obturator nerve might be? and examining all the distal musculature. So the dermatomal patterns are helpful for a spine exam if you're worried about spine, but for acetabular fractures, we worry much more about nerves, peripheral nerves, and so we want to examine the peripheral nerve function, both motor and sensory, distal. And then very important is to examine the knee. A lot of these acetabular fractures can be from car accidents or axial loading of the knee, and you can have associated injuries in knee dislocations or ligamentous knee injuries that may be masked in terms of pain because the hip is dislocated. So looking for knee dislocations, knee injuries, or other fractures of the lower extremity is important.
Such important points. I think if you're a student and you're listening, going to be a resident, and you want to excel, a couple of pearls. First, you reduce a hip, you got an opportunity to examine the knee right there. And so if you do that and then report to your faculty, I reduced the hip, I also stressed the knee, and the knee was stable, it will put you at a level, a tier way above, just to know the association and that you've done that. And the secondly, I feel like all I hear is neurovascular intact, neurovascular intact, neurovascular intact. It's like it would be really impressive to have someone say, I also assessed the dorsiflexion, I assessed tib and EHL, both are intact in a hip dislocation specifically. You immediately recognize that this person was assessing the sciatic nerve, knows that there's an association. So as if there's anybody listening who's about to start their intern year and you see a hip dislocation, you present it in that way, you will set yourself apart as knowing what to look for. So early management, things that you want to consider: antibiotics for open fractures. You want to reduce hip dislocations. For those hips that are unstable, that they may not stay in the socket, you want to consider traction. That may be dependent on your institution. If they've got pelvic ring injuries, you may want to apply a binder. And then there may be situations, we may show a few later, where resuscitation is going to be critically important, and interventional radiology may even be in play. So some of these injuries, like the one shown here, you're going to lose a liter of blood in this hip socket. We talk about it all with femurs, but you're going to lose a liter of blood from this hip injury alone. So, Andrew, give us your kind of reduction technique. I guess what way have you found to be most effective to get a posterior hip dislocation in?
Yeah, for sure. So I think point number one, adequate sedation is probably the biggest thing. A lot of times we'll go down to the emergency room and they'll say, "Oh yeah, we gave them a little bit," and honestly, the patient's still grimacing. You're still feeling them fight against you. If you can get adequate sedation, that goes a mile. Pelvic stabilization is very important. So just pulling on a leg means you're going to pull the leg, the hip, and the pelvis with it. And so you need to make sure that somebody's stabilizing that pelvis for you so you have a solid surface to pull against. Flexion of the hip, the idea is to kind of, for a posterior hip dislocation, is to basically bring the femoral head out from behind the posterior wall and back into the socket. And so that's what flexion helps do for you. Now, again, there are some patterns that if you're not careful, you can actually break the femoral neck. And so it's important to kind of discuss some of these radiographic findings with either your residents or your faculty. Internal rotation as well as adduction of the limb will also help unlock that head from behind the posterior wall. And then finally, axial traction will bring the hip past the posterior wall and back into the socket. And so my preference is typically I will have an assistant holding the pelvis, and I will actually get up on the bed, grab that leg, and kind of lean back with my weight, just so I'm not kind of cranking or anything like that.
Anything to add there, Patrick? Are you kind of a Captain Morgan type of guy, or how do you do
Yeah,
it?
no, I'm not as agile as Dr. Tyler. So if I get up on the bed, I'm more likely to end up with a hip dislocation as well. So I used to, when I was in residency in the emergency department, I used to shift the patient over to the side of the bed that's on the contralateral side, so the injured hip is more in the middle. Have an assistant push on the pelvis, and I'd stand on the opposite side, flex the hip, internally rotate, adduct, because you're pulling the hip to that side anyways. When you're trying to lift it and you're standing on the opposite side, that hip adducts, and then I would put the bed as low as you can go. So I was not a bed climber, but it certainly makes for heroics in the emergency department.
That's right. Very nice.
It should
So here,
probably be noted that's all for posterior too, right? Like
all for
Yes.
posterior.
very, very rarely do we see anterior dislocations, but they do happen, so be mindful.
Great point. So here's the post reduction. We see that internal rotation of the femur has corrected. We're now seeing more of the lesser trochanter. The bone fragment is now moved more anatomically, a little bit closer to its docking site. And we see maybe a little bit of subtle incongruity in the joint still. And that's a particularly important pearl on these if there are fragments in the joint that you still need to go retrieve. So, Patrick, distal femur traction, kind of break it down for us. What should a student know about how to put in distal femur traction?
Yeah, so I think the most important parts of doing any type of invasive maneuver for medical students or interns is to make sure that you're doing it on the correct limb. So always confirm on radiographs. Don't read radiology reports. Pull up the actual images to look to make sure that you're placing the traction on the correct limb. And then make sure you've chalked with the senior or the faculty to make sure that it's appropriate to place traction. And then for distal femoral traction, it's knowing your surface anatomy. It comes back to being able to palpate certain parts of the knee to make sure that you're going in a safe area where there's no hazards such as the femoral artery or the knee joint that you'll leave a pin through the knee joint or a pin that could potentially injure the femoral artery. So you'll palpate the superior pole of the patella, which is almost always palpable, or patients that are able to palpate the adductor tubercle. You'll go 2 finger breadths above that, and that'll almost always get you out of the knee joint. And then you go from medial to lateral. You want to start from known anatomy to go to unknown anatomy. So you'll insert the wire on the medial side, and you'll palpate the anterior and posterior margins of the cortical bone. And then you'll insert through the middle part of the femur the wire that's parallel to the knee joint. But it's important to start on the medial side so you know that you're not potentially getting the femoral artery if your trajectory is off. The lateral side is much more forgiving as it doesn't have as many anatomic structures that are dangerous. When to avoid distal femurs, ipsilateral open or ipsilateral distal femur fractures. You don't want to place a wire through a femur fracture. And then open wounds, if there's open wounds around that knee that the wire would potentially go through, it might be better to place proximal tibial traction.
Aker, I got a question. So a lot of our residents get x-rays of the femur every time before they put in a distal femur traction pin. To Patrick's point, to make sure they don't put a wire through a fracture, to make sure they don't end up seeing a lesion in the distal femur. Do you think that should be a routine part of practice for students as they kind of start to say, well, I'm gonna put in distal femur traction. I need to get an x-ray of the femur before I put in this pin?
I think that's just best practice. It's safe. A lot of programs out there. Certainly my residency 20 years ago, we did proximal tibial traction pins. So you really want to be aware that, maybe there's some instability in the knee or there's a tibial plateau fracture. You never want to be that resident that accidentally put a pin through a fracture or, heaven forbid, hang some traction from the proximal tibia and then sublux or dislocate an unstable knee injury that was previously not seen. So imaging is and can be your best friend. So yes, absolutely.
Are there any, so you've seen a lot of traction pins put in well, put in poorly, the bows put on well, put on poorly. Any pearls about that, things to avoid outside of associated injuries to not get a call from your attending to say, hey, what the hell is this pin that you put in?
Yeah, I mean, probably the most common that people are aware of is the air ball, the traction pin that's too anterior in the distal femur or the proximal tibia, and the resident doesn't even pick up on it, and they still connect it to a bow, and you're pulling traction essentially through skin and periosteum, which can be very, very damaging to the soft tissues and lead to ulcerations and skin breakdown. So I don't mind an x-ray after the traction pin, but hopefully it's confirming what you already know. You put in a bicortical pin, the techniques that were described of palpating with the wire, anterior, posterior, bam, go midline, and away we go. But I would say the anterior air ball is for sure the most common error that we see.
Awesome. So, Patrick, how'd this guy do?
Yeah, so this guy underwent fixation of his posterior wall fracture through a posterior approach, and he got back to all the sports he wanted to do. I actually saw him in clinic recently. He's back on the football team. He's running track. He runs the 400 meters, and he has no hip pain. And he's looking to play football in college next year. So he did really well, and these kind of highlights the importance of managing these reductions early. I think we didn't talk about it, but hip reductions are an important thing to get to quick. They aren't something that should be sat on. It's not something you can just let go and do some other consults and get back to. The time that the hip is out does lead to higher rates of problems with longevity of the hip joint. So getting these quickly and stable fixation lets patients like this patient get back to all the things they want to do.
Awesome. Taylor, we got any questions loaded up in the chat box?
No questions. We got a crowd of experts here.
There we go. Good stuff.
Already acetabular fractures, tough topic, but no, definitely ask some questions.
Okay. So next case, 60-year-old female MVC. Andrew, can you kind of contrast the last X-ray that we started with this one for us? What do you see that's the same? What's different?
For sure. So I think the most obvious thing in this case is that the hip is reduced. In Patrick's case that he was just talking about, hip was way off in left field, and it was pretty obvious what we were looking at here. Hip looks good on both the X-ray as well as the CT scan. Another difference that Patrick kind of pointed out is on that X-ray, you could very clearly see kind of that fleck of posterior wall on his X-rays. Here, X-rays aren't giving you too much as far as the injury pattern. You really need the CT to help define some of what's going on, and that's what you got on the right here. And while this shows you, yes, there is a posterior wall fracture, but it seems a lot smaller than the one that we looked at before. There may be some impaction as well on this that we're looking at. But most importantly, it looks like we have a pretty concentric reduction, and it's a pretty caudal or kind of low posterior wall as well. So we have what seems like maybe a stable hip.
Okay. So in terms of talking about this patient, just looking at the surface rendering again to reflect what Andrew was just saying, a small piece of posterior wall. Kind of talk to us about the role of EUA. So this may come up for students as they're getting into cases and seeing that for an acetabular fracture, somebody may start and actually push on the hip, although it wasn't dislocated. What is the EUA meant to look for?
Yeah. So the EUA is meant to look for kind of this more dynamic instability. And so we use it a lot of times when we have these small posterior wall fractures that we're like, well, do we need to fix it, or is this going to be a stable hip that's going to stay in the joint? And so this is showing two images of an EUA. And the way you actually do it is you take them to the OR, you get them relaxed, you bring the C-arm in, and you get this view. This is called an obturator oblique that we're going to talk about here in a sec. You bring the hip up in that kind of adducted, flexed, internally rotated position, and then you just push on it. And what we're seeing here is on the left, that's before we push on it. But on the right, I think we're going to pull up some lines. There you go. We see a little bit of increase in this clear space on this medial side, which suggests there's an element of dynamic instability going on here. And this is not going to be a happy hip if we just let this guy walk on it.
Yeah, so thinking back to the first case, a hip with a large posterior wall that was dislocated. In that patient, if let's say we decide to go with non-operative treatment and let him walk, what would be the end result for that type of case, Patrick, in your mind? If that patient says, I refuse, I don't like surgery, I don't want to do it at all, take my traction pin out, I want to go home.
Yeah, I think if there's any level of instability that this becomes, there's subtle motion, and cartilage we know doesn't like shear. It doesn't like to slide on itself in an unstable pattern where it keeps slipping and having shear forces as opposed to just the concentric movement. So any sort of instability in a hip that's left non-operatively treated and unstable will lead to pretty quick arthritis.
Okay, perfect. So I wanted to use this last case to discuss the obturator oblique and the iliac oblique X-ray. So these Judet films, and As a student, you may see those in clinic as they get clicked through and you see the AP pelvis, and then you see additional x-rays looking at the acetabulum. That last picture with the hip flex up, seeing if the hip was going to dislocate, was done on an obturator oblique x-ray. So a x-ray that's shot with the hip, the acetabulum at an angle to assess certain components of it. So getting back to the columns, this is where you're going to start hearing those words. So Andrew, just briefly tell us this obturator oblique, what does it look for? Why do we get a oblique x-ray?
Yeah. So an oblique x-ray is because of the innominate bone or the acetabulum has so many curves on it, you kind of have to take oblique views just to make sure you capture everything. And so this one, as we said, is the obturator oblique. And we know it's that because number 3, we're looking at the obturator foramen. And so that's how you know it's an obturator oblique. And here what we're seeing, this really looks for posterior wall and anterior column. And so one is going to be your anterior column, like we were talking about before, that blue area on the pelvis, and then your posterior wall, which is that green line right there. And this will show kind of displacement of those two areas predominantly.
So on that EUA that we just showed, we're getting the obturator oblique, which shows the posterior wall the best to assess if there's displacement of the wall and if the hip sublux. And then the counter to that is the iliac oblique. So 90 degrees the other way, we get an x-ray here now of the posterior column shown in red, and then the anterior wall shown in orange. So you all may see these in clinic. You'll see them in cases, acetabular cases, as folks get oblique views to look at these specific areas of bone that an AP pelvis may not show. So this patient had repair of her posterior wall with a plate similar to shown in Patrick's case. And here's the post-op x-ray, and at a year, follow-up was doing well, no hip arthritis. I want to hit a bonus case, a counter to that. And so this is a patient I saw about a year ago. She's in her mid-60s, looks like she's in her mid to late 70s. And she had a hip fracture on the left side. Similar to the last case, it's hard to see on the plain film, but when we look at the CT scan, so these are the axial cuts of the CT, that left hip, it's on the right side of our screen, but that left hip, you can see the posterior wall. And so she, again, this is not a wall that's tremendously displaced. She was treated non-operatively, and we elected that if she went on to arthritis, that she would get a total hip at that point. Here's the surface rendering, similar, hard to even see the wall. It's a small crack in the bone. These are follow-ups in clinic over 2 months. So you can see with instability what can happen to a hip. The initial x-ray on the far left with a reasonable joint space, very quickly over months going away secondary to micromotion, and eventually getting her total hip later. So just highlighting that stability is key. We're going to hit one more case of the posterior wall before we change to some anterior based cases. Andrew, this is a case of yours. Describe what you see on this. I'm seeing more. It seemed like some of those last cases, I couldn't see the wall. Maybe there was a bone fleck here. This looks broken to me. How are you reading it? How would you want a student to read it as you said, all right, read this x-ray for me as you're sitting in clinic?
Yeah. And so I think this x-ray, so this is a case of mine, a 37-year-old male who's in an MBC. It has a lot of similarities with Patrick's case. And so you can see that the sourceal, or the kind of the dome of the acetabulum, the hip isn't under that. So like Patrick's case, this is a hip dislocation. Also like Patrick's case, you can see the wall kind of right next to that letter L there, and it looks like a posterior wall fracture. But there's a little bit more going on here as well. So if you look just medial or just kind of inside to the femoral head, you're starting to see some more fracture lines going on there. And this is where we get into the columns. So these are now disrupting our anterior and posterior columns. And that's really what I want medical students to kind of pick up on. Now here again, we're showing the iliac oblique on the left, and then the obturator oblique on the right. And starting with the obturator oblique on the right, again, we see the hip is dislocated. We can see kind of that fleck of posterior wall that's superimposed on the right hip. But we can also see that the anterior column is disrupted. Like we said before, the obturator oblique shows us the anterior column and the posterior wall. On the left, we're looking at our iliac oblique. And while it's a little hard to see, we can actually see that there's some step up of the posterior column, because again, the iliac oblique is showing us the posterior column and the anterior wall. And so this is going to be one of those excuse me, associated patterns that we're talking about, as opposed to the elementary patterns of just the posterior wall.
Yeah, so when we have students in clinic, and I think many of us use these lines to ask students to say, hey, how do you interpret this X-ray of an acetabular fracture? Walking through these 6 lines is going to be a way to stay safe, similar to Walter and describe how to describe an X-ray, but how to stay safe and make sure you're hitting all the major points. So going through this film, the iliopectineal line represents the anterior column. These are all like words that initially sound foreign, like a different language, but the more you hear them, and hopefully tonight, maybe the first time, but you keep digesting and digesting, and it suddenly becomes your second language, like it is for many of us. Ilioischial line for your posterior column, your teardrop, your sourcile or the roof of your acetabulum, the anterior wall shown on the X-ray, and the posterior wall. So you can see a lot on a plain film. And for those students who are starting to look at plain films and starting to see some of these lines, seeing a lot of normal is going to be really helpful. So going back to this case, we can now see that both lines are disrupted, iliopectineal and ilioischial. So both columns are disrupted, and that is going to be helpful for us to decide where it's going to fit in the classification scheme. So we showed a case with a posterior wall fracture before. That's shown on the yellow here. This is the CT scan, which shows an additional fracture line in blue. And this is that transverse fracture line here that interrupts both the anterior and posterior columns. So a more complicated acetabular fracture, not just the posterior wall, but now both columns are involved, representing a transverse. So here's the follow-ups, beautiful X-ray, Dr. Tyler there for the transverse posterior wall acetabular fracture. So in summary, posterior wall is the most common pattern, 55 to 60%. So as a resident, this is what you're going to see most commonly. It's commonly associated with the dislocation, mostly a posterior dislocation. We talked a little bit about how to manage it in the ER, some reduction techniques. Nobody here does Captain Morgan, but I guess we have some who stand on the bed, some who shift to the side of the bed, but you'll see different ways that residents do it, and you may find that one way works best for you for whatever reason. And then we talked a little bit about why to fix, when to just examine under anesthesia, and then when maybe non-operative care should be entertained. Any questions, Taylor, before we move on to some anterior moieties?
It may be useful to talk a little bit about dealing with incarcerated fragments, especially bigger ones, maybe.
Yeah, so we don't want to leave any pieces in the joint. We don't want incongruity of the hip joint, and it's not uncommon for a hip to be dislocated, and then as the hip gets reduced, it to pull pieces back into the hip socket. So the first key for that is identifying them, uh, counting them, measuring them, knowing what you're going in to get, and then there are many different techniques of how to do that. So we probably each use some similar and some different, whether it's putting on a distractor on the hip, uh, pulling with a Chance pin, a distract, probably depends on how big the wall is in terms of how much you can access, but lots of different techniques to get them. So I don't know. Have you? Go ahead, Patrick.
Yeah, I think the other important thing for the medical students and early residents and interns is if you notice that on a post-reduction CT or in a CT that there is a fragment that's in the joint that's between the femoral head and the top of the joint, that's a great indication for traction. Maybe something you didn't think your institution, maybe you don't do a lot of traction, but the traction can help relieve the cartilage, the pressure on the cartilage between the femoral head and the roof of the acetabulum. So that's a great indication for skeletal traction that we showed earlier, so that the hip joint can, the cartilage can be preserved overnight before the patient goes to the operating room in the morning.
Perfect. Yeah, that's sort of what I was getting at there.
Perfect. All right, next case here, 71-year-old. Andrew, what do you see? How would you want this to be described to you?
Yeah, so this is now a little bit different from our first 2 examples, and so a couple of things that you want to pay attention to. So first off, you want to look at your lines, your iliopectineal and ilioischial line, and here it looks like both of those are disrupted. Furthermore, it also looks like our source seal, our dome that we were talking about before, also now has a little bit of a break in it, and almost kind of what we call a gull wing, where it kind of we get a little bit of impaction of that dome. Finally, instead of a posterior hip dislocation, what we're starting to get is some medialization of the head, meaning the head is starting to go kind of in toward the pelvis, as opposed to kind of outside of the hip, like the posterior hip dislocation.
Nice. Tim, so you've seen a number of these over the years. What should a student know about a 71-year-old ground level fall with an acetabular fracture?
I think that if they were queried on this type of fracture, um, in general, it's going to be one of two types of fractures every time, almost without exception. So, um, if they could just remember that this is either going to be an anterior column, posterior hemitransverse, or an associated both column, they're probably going to be right probably 90% of the time if they happen to be pimped on that. Old folks that fall down, land on the hip, usually get intertrachs, but if the hip fractures on the other side, it's usually one of those two patterns, which would be like really extra credit bonus points if they knew that.
Perfect. So here's the post traction X-ray. And so a good indication here for traction, you can see that impacted piece that Andrew pointed out is now offloaded. There's more space on the medial part of the joint than there is on the lateral as that impacted piece was left cranial. So a good indication for traction. Patrick, so acetabulum approaches come up. We've just reviewed a few cases with a posterior based approach. There's an anterior based approach as well. What you've got a student in clinic with you. What do you want them to know about acetabular approaches?
Yeah, I think the big thing is that there are two main approaches to the acetabulum that we use currently, and one is a Coker-Langenbeck and one is a ilioinguinal, or there are certain parts of the ilioinguinal, but an anterior approach to the acetabulum or a posterior approach to the acetabulum. And I think that it's important for students to know why we do each of those, but largely the most important thing of approaches as a medical student is that those are the two ways that we get to acetabular fractures. They're almost largely treated through either one of those. And then there are some fine details about that as you guys get through your training, but I think largely it's just to know that those are the two types of acetabular approaches that we have.
That's perfect. Yeah, I think you don't have to know how the fracture is going to be fixed or even the sequence sometimes, but when a student comes and has read about what a Coker-Langenbeck approach entails and that we're doing a posterior wall and that's why we're doing a Coker-Langenbeck, that is really a great place to start and we'll elevate the discussion at that point. We don't have to go through some of the basics and show, just some of the where the external rotators are. We can start talking about um, more interesting things and get you over on this side of the table. Why don't you see how this fracture gets put back together? And why don't you put in a screw? So if you can bring that level of interest and that level of early knowledge, you can make a big difference. So here's a really nice pictogram that Patrick put together. I think in these are around, if you take a screenshot of these and you start looking at the surface renderings and rotating some of these cases and saying, all right, what am I going to see from the Coker-Langenbeck? That's really some extra credit points, and it's going to make it a much better, more interesting case for you as well as you all get started. So the Coker-Langenbeck approach, here's some of the anatomy. Again, there's great resources. AO is an amazing, amazing surgical reference for these with great pictograms and has pictures like this showing that. I got to show this video from Patrick. Patrick, what is happening here? What is this?
Yeah, this is a video of a large artery that's on top of the sciatic nerve. But really what it shows is the surgical visualization that we get through a Coker-Langenbeck. I think oftentimes medical students think that we make these large incisions on, we see it drawn out, that we're going to see a vast landscape of the posterior column of the posterior wall. We're going to see a lot of anatomy, a lot of bone. But you honestly don't. Each layer you go down, you get less and less visualization. So this is a pretty standard approach or visualization of this was a transverse posterior wall fracture that We see, and so the freer tip there is on the sciatic nerve. The rich retractor up on the top of the screen is holding back the gluteus maximus. The Sofield retractor on your right is holding back the gluteus medius. And then the sutures that you can see are through the obturator internus. And so those metal things are the plates we put on, and then that white band on the left side is the vastus lateralis. And so this is a pretty classic look of through a Coker Langenbeck.
It's beautiful, beautiful video. Similarly, the AO reference for the ilioinguinal, I think it's a beautiful approach. And if for students, if you get the opportunity to scrub into one, really a memorable opportunity as well to see what you can see from really a classic approach, but more of an anterior-based approach that's going to show the anterior surfaces of the hip. So again, just want to plug the AO surgery reference. Amazing, amazing reference. So going back to what Dr. Aker mentioned about that anterior column, posterior hemitransverse, I think as y'all are thinking about approaches and deciding, well, which would be the best to fix this, it comes back to instability. So in these patterns, the hip is going to go through either medialization type of displacement that Andrew mentioned, or superior. And that's best shown in this left-sided image where the barn doors have opened and you can see the femoral head inside the fracture on that image on the left. And that's where the femoral head's going to go without stabilization through plates and screws typically. If you approach it posteriorly, this is the view you get on this type of fracture. You get to see the single fracture line, but you won't be able to prevent the femoral head from going where it wants to go. So in terms of deciding approach, instability is what's going to most often drive your approach. So here's the follow-up, a beautiful X-ray of a anterior column posterior hemitransverse repair. You can see the staple line. So what approach did you choose in this case, Dr. Tyler?
Yeah, so this was a classic ilioinguinal. We opened all three windows in order to expose the fracture appropriately and be able to reach some of that impaction as well. And I think something important to note is that just because we're going anteriorly doesn't mean we're also not getting fixation in the posterior column. And that's what those long kind of drop down screws are doing, are getting fixation in our posterior column as well.
It's fantastic. Beautiful follow-up image here. Really a beautiful case. So we're going to go to another similar but different 38-year-old MVC case of mine. What stands out? What jumps out at you, Aker, with this X-ray, this AP pelvis? Resident puts it up on the screen. What are you looking at?
Yeah, I mean, something eyes are always drawn to the abnormal skeletal pathology, but one of our friends and mentors, Dr. Chip Rout, always likes to talk about the soft tissue windows and the soft tissue shadows. And just look at the bladder, look at the contrast that's in the bladder. And you know that there's just a massive hematoma on the right side. So hematoma like that, you may even be wondering about, does this patient need a CT angio? Do they need a squirt? Do they need to go to IR? Is there a blush somewhere that's causing this? Or is it truly just a slow venous ooze that's compressing against the bladder? Similarly, though, anytime that you see the posterior column or that medialization of part of the acetabulum, um, you have to have concern. Just like you were saying earlier about did you test the tibialis anterior and neurovascularly intact? This is one I would my antenna would go up for a possible foot drop or an injury to the sciatic nerve. So lots of soft tissue potential injuries with this pattern.
Awesome. So here's the 3D reconstructions. And these, again, I think have been so helpful to take and turn and see, and what are you going to see? And so as you take it and you take your fluoros, your ghost on the left, and then you lay them over the top of your surface rending, and you begin to see what you're going to see during the case that, oh, that spike of bone out there on the periphery that we see indicated by the arrow, we can see that on the surface rendering too. And so that's an important piece of bone. You'll hear it referred to names. I'm on a webinar right now with 4 Texans. So which Texan wants to tell the students about what that is? Andrew Tyler, I see you gyrating a little bit. Yeah.
That's right. So representing West Texas, that is called the spur sign, and that represents the intact ilium that's still connected to your sacroiliac joint, whereas the rest of the acetabulum and the rest of the joint is kind of free floating at this point.
Yeah, so everything is displaced away from that intact spur. So we know we did a great job when everything gets put back and reconstructed to it. So you'll see that on the obturator oblique. And if this gets presented, and as a student, you say, well, there's also a spur sign I saw on the obturator oblique, my head will explode and we'll be able to elevate the discussion already. You'll be dropping screws. It's going to be a great case. So I think some of these details, they're small, little pieces of knowledge, but they mean a lot to us and to the case often because I know we're trying to build everything back, and I know that things are right once we're back onto that spur. So iliac oblique, you can see the displacement through the posterior column here as well, and you can see how displaced the posterior column with the sciatic notch is. And so, Patrick, what do you think? Approaches for this case, additional considerations, and ultimate outcome. Associated both columns sounds bad. It's like the 10 on the 10 patterns, it's number 10. It's like it's the worst, you know. So, what is your expectation from an outcome standpoint for a kid like this?
Yeah, so I think approach wise, this is an anterior approach. The parts of the fracture that you need to see are in the anterior portion. If you look at this iliac oblique, all of the fracture planes are in that green surface that we had on the image prior. So that's you can see everything you need to for that fracture. The considerations that Dr. Aker brought up of the hematoma, the bladder being displaced to the contralateral side, that makes me worried about some kind of vascular injury. And so being aware that there could be a lot of bleeding in this case, like you brought up, Dr. Mitchell, and having a lot of conversations with your anesthesiologist, making sure the patient's safe when you do this surgery. But associated both columns come in a lot of different varieties, but this one looks like it has some we call nice large pieces with minimal joint impaction. So the joints that's on the fracture pieces are not displaced on that fracture piece. So they're all where they need to be once you get the fracture pieces home and reduced. And so I would imagine that with the skills that you have, Dr. Mitchell, this patient gets an anatomic reduction and does quite well, despite the terribleness looking of this fracture.
Yeah, I think I was most worried about the hematoma. I think that's such a apt and important thing. It's like if we get through the fix, going to do fantastic, but
Yeah.
it's getting there and doing it in a safe way. So if you look at his posterior column, we'll talk a little bit about the anatomy in the next case, but his superior gluteal artery was in on the other side of the fracture site. It was as big as my pinky finger. It was enormous, congested, and dissecting that off in a hole, I think was the biggest challenge. But once it was done, it was done. And this was the post-op, and ended up doing just fine once we got past that point, and I could finally take a breath. So these generally both columns do well, young, big pieces in general, and that's a good case. So we're going to move on to a few more here. I think this highlights some of the concerns in the last case too. So Patrick, walk us through this. 61-year-old fell through 6 feet. What do you see on this plain film?
Yeah, you see displacement of the posterior column there. There's some an ilioischial line you could maybe say is intact, but partially disrupted there. And you see a right-sided acetabulum fracture, but altogether, you wouldn't say that this was nearly as bad as the fracture that was just shown. The hip joint is maybe a little medially subluxated, but maybe similar to the contralateral side. But it's reduced and nothing overwhelmingly surprising on this film or terrifying on this film yet.
Yeah, I think a nice count, showing an intact iliopectineal or anterior column, and then you can see the spike just of that ilioischial just peeking out just a little bit, just saying, review the CT, see what's coming. So here's the CT. I'm going to slow down because there's a really important slice here, right there. So
Yeah,
why?
so off.
Yeah, go for it.
Yeah, oftentimes patients get CTAs or they get contrast in their arteries so that we can look at arterial injuries. And this is similar to what Dr. Mitchell was saying in the last case. That spike of bone is right where the superior gluteal artery exits the greater sciatic notch. And that blush that Dr. Aker mentioned earlier, that's contrast. That's a big slug of contrast that's in a vessel right there. And it's maybe not contained. You know, knowing your anatomy and how the vascular arteries go between the notch, if it goes in a pattern that you're not expecting, that can be a blush of fluid, or it doesn't look like a tube. There's a little bit of some flowering or fingers going out. That's something that's concerning, that there's an arterial injury. And so that's a very concerning sign for a superior gluteal artery injury.
It's awesome. A beautiful 3D reconstruction showing from side to side the normal where it would sit and then the proximity of how that fracture exited right where it comes out and how it would, that sharp fracture edge, whether through tension or through more of a direct contact created injury. So, how did you handle that in this case?
Yeah, this patient underwent open direction internal fixation in a delayed fashion. We did not get IR involved, and so we attempted to do just some delayed fixation to allow the artery to heal. However, unfortunately, when we got into the Coker-Langenbeck and we reduced the fracture, there was a lot of bleeding, and so we had to. You can see on the post-operative CT, there's some vascular clips. We had to find the superior gluteal artery and cauterize it with the help of some of our general surgery colleagues that were providing some vascular assistance to us. But a good thing that probably this patient would have benefited from a superior gluteal artery embolization prior to surgery.
Very nice. Yeah, those are high flow vessels, and when they start going, it will quicken the pulse. So, always good to have a plan. We're going to finish with this case, Patrick. A nice one of yours. What's standing out to you on this X-ray?
Yeah, this is a 74-year-old lady who fell down the stairs, so maybe a little bit higher of an injury, but I think what's most notable is the sourceal, the dome, the roof of the acetabulum is not largely displaced, but the femoral head seems to be impacted onto that part of the bone, and everything is just crunched inwards. There's just it looks like it's pretty comminuted. There's flakes of bones everywhere, but it's not a terribly displaced fracture. And so this gives me concern about bone quality as well as femoral head involvement. But this patient's healthy and walks, and so 2 to 3 miles a day. So we don't want to treat her non-operatively, or we want to give her the best functional outcome going forward. And we know that femoral head involvement in acetabular fractures portends a worse outcome. And as you can see there, there is some joint impaction, meaning the cartilage in the subchondral bone is separated from all the rest of the bone. The femoral head has a lesion on it. It's been impacted. And so these are all markers that have worse outcomes for acetabular fractures, largely because sometimes they're hard to get to, and sometimes there's nothing really to do about the femoral head impaction. It's hard to regrow cartilage overnight.
So tell us a little about the decision making then to go to this operation, and what is it? I see some plates. I see some kind of arthroplasty type components as well.
So this patient we had a long discussion with about fixation versus an arthroplasty, and what we decided on was limited fixation. So in order to get arthroplasty in, an acetabular component, you do need stability. You can't just free float an acetabular component in an unstable fracture. So the plates are providing a tension band or tension of that posterior column piece to allow me to place an acetabular component that then has those long screws that go cranial to allow fixation of the cup into the bone. And then we do a total hip arthroplasty that allows her to walk on this at an early recovery, and allows her early mobilization with minimal pain, and allows her to get back to all of her activities without a secondary surgery.
Awesome. So we covered a lot. We introduced different patterns, the classification scheme. Again, if you're going to hit anything and be ready for your clinic with your trauma Faculty, you may go over some acetabular cases. Knowledge of that's going to be incredibly helpful. How to perform a hip reduction safely, how to place traction, when to place traction, when not to place traction. Some of the imaging as well, including the Judet films to get familiar with, and then how to apply these to cases. And then lastly, the surgical approaches, and then when we fix, and then when we don't, and then some of when we replace. So, Taylor, any questions to hit as we wrap up?
Yeah, I think there was a couple of questions about how the plates are functioning, and I think at least one of the statements I'd reiterate is that you are the surgeon and you determine how the plates are functioning using your AO principles, right? In a lot of these cases, the plates are functioning as buttressing implants, but you can still use them in and around the pelvis in a bridging fashion as well, or neutralizing, but in general. A lot of these are buttressing implants. Sometimes you may put a lag by technique screw through the plate itself, but the principles remain the same, even if the injuries are complex and sometimes extremely challenging. But the principles, you want to lean back on them always.
Awesome message. Dr. Aker, you want to add anything as we wrap up here?
No, I really thought that was a great session, great variety of cases, excellent surgical examples. I mean, the students should understand that these are really very accomplished, top-notch surgeons that are showing really beautiful examples of how to reconstruct these injuries. But their x-rays are making it look easy, and there's a reason why this is the last module in this year's session, because this is sort of like the pinnacle. The surgeons that can fix these are absolutely have reached kind of the ultimate. These are really challenging fractures to think about, to preoperatively plan for, to study. When I was first getting into this field, I would study the CT scan for hours before going to the operating room. I mean, really, really, truly study these injuries. And these guys make it look easy. So hats off to them for doing such a fine example this evening. But I thought that was a really wonderful AO Link webinar to wrap up this season.
Absolutely. Thank you to Andrew and Patrick. I have to echo Tim. It's just always awesome to see the great work y'all are providing for folks in Texas. And again, highly complex injuries. We go over the superior gluteal blush, in 30 seconds when that would probably have taken about 30 months off of my life, just thinking about and talking to people and what do we do and how do we manage and what if it bleeds and it started bleeding and getting the other team in here. So I think again, there's a lot of thought that goes into that. So really appreciate y'all's cases. They were truly excellent. So want to say at the end here, if you have hit all 9 sessions and this is number 10, get your Credly badge, get your merit badge, put it on that application. Love to see it. And you should. It's just been an incredible year going through this. I just want to give a shout out to all of the staff who help us, and to my co-host, Dr. Young here, and then to our leader, Dr. Aker, who brings the excitement, the energy for education, and truly is world class in that arena. So thank you all. Get ready for 3.0. It won't be the same, but it probably will be better. So we'll keep on getting better and better, and we appreciate everybody's time. And y'all have a great night. Thank you, guys.